Good morning. I want to welcome you back to St. Norbert College and the CEO Breakfast and Strategy Series. Another great turnout this morning, which is no surprise given the subject and given our speaker this morning. But I do want to say we're particularly appreciative for you coming out, and not the most pleasant day to be out driving and walking, so make sure you take care getting back to your cars and getting back to work afterward. So delighted to have you back for the CEO Breakfast. I'm Tom Kunkel, president of St. Norbert, and along with our sponsors, we're just delighted that you could be with us again this morning. This is the 19th year that we've been offering the CEO series, providing area executives with the opportunity to hear from some of our top CEOs. This resource is being brought to you through the generosity of our presenting sponsor, that's WPS Health Insurance, Arise Health Plan. And our title sponsors, Wipfli, Insight Publications, Johnson Bank, Johnson Insurance, and the sponsor of this morning's session, Bank Mutual. If you would, please take the folders at your place with you when you go and take a little time to review the information. We would really appreciate it. At this time, I'd like to ask up my friend and colleague, Father Sal Cuccia, who is Campus Minister Emeritus, to offer grace. Sal?
Loving God, all things are of your making. Enrich our hearts with the spirit of wisdom and understanding, the spirit of knowledge and counsel. Help us to be open to new possibilities, to accept the challenges of new ways of using our gifts and talents for the service of others. Bless this food we are about to share. As we are nourished by it, may we be mindful of those who are in need. May it give us strength of mind and body, so that by word and example, we may do your work more effectively. We pray through Christ our Lord. Amen.
Thank you, Sal. Enjoy your breakfast, and we'll be back with the program in a little bit. Well, good morning again, everybody. Hope you enjoyed your breakfast. All right. There we go. Good job. Okay. Need everybody paying attention this morning because this is a big topic, and as the president said, it turns out it's complicated. But Ashok is going to explain it all to us this morning. It's a real pleasure for me to introduce today's speaker, Dr. Ashok Rai. Ashok is president and CEO of Prevea Health, the largest multi-specialty group practice in Northeast Wisconsin. And he has a personal commitment to the wellness of this community and continues to inspire others to live healthy. His association with Prevea Health began in 2001 when he joined Prevea's partner hospital, HSHS St. Mary's, as the medical director for hospitalist services. During the past 15 years, Dr. Rai has also served as St. Mary's physician quality director and Prevea's associate medical director of operations, senior vice president, and chief medical officer. His passion to redesign healthcare extends nationally and is about to be tested big time. And he was recently named as the chair-elect for the board of directors of the AMGA, a national association of medical groups leading the transformation of healthcare in this country. His passion for wellness has led Prevea to embrace the patient-centered medical home model of care, bringing patient-centric care beyond the clinic and directly out into the community and even the workplace. I'm also proud to say that Prevea is the healthcare partner for our St. Norbert College athletics program. Prevea's customized care educates and empowers individuals to lead a healthy and fit lifestyle, thereby improving the total wellness of the region. Please welcome Dr. Ashok Rai.
Good morning, everyone. I am honored to speak today, but before I begin, I'd like to thank Tom and Deb for your contribution to this community over the years. It's been an honor to get to know you, to work with you. Not only has the St. Norbert's campus benefited from your tenure here, but really our whole community has, and you deserve a round of applause. So when I got asked to give this speech, it was, I think, late summer, early fall, and I was pretty confident I knew what I'd be talking about. It's a path that we'd been on for 8 years. Something happened in November, so I have 20 blank slides for you today. Actually, I don't think our path has changed at all, and I'll talk a little bit about that. You know, the topic I want to talk about today, and obviously there's a political nature to healthcare these days, if you haven't heard. And I'll touch on some of that, at least of what we know. And as Tom mentioned, I have a little bit of a national role right now. And during the Q&A, happy to answer at least what I know from my recent trips to Washington about that subject. But really, you know, what I wanted to talk about today is kind of how we got here. If you think about, and I don't mean how we got here for 8 years, but for the last 20, 30 years, how did healthcare get so expensive? What drove us to that? And then what can we do about it? And it really is that path from volume to value in healthcare. We talk about it a lot. And if you really look at the traditional way on how we made our money in healthcare, guess what? We're a business. And it's an unfortunate aspect of our careers, but we are a business. The focus was completely on the sick. As Tom mentioned, I began my career in 2001 as a hospitalist at St. Mary's. And for those of you who don't know what a hospitalist is, my entire job was to take care of those who were sick in the hospital, specifically the ICU. So for the first part of my career, I spent my entire life focusing on the failures of medicine. Because I look at a hospital admission sometimes as a failure in medicine. What did we do to prevent, what could we have done to prevent this? How many times have I pushed on a chest or had to stand, you know, get on one knee in an ICU knowing, as I'm talking to a family, that this was a preventable situation? And it's actually what drove me into healthcare administration, except for the fact that I went to the bathroom at the wrong time, got elected to a committee, and next thing you know, you're the CEO. But really, I got frustrated, and I still practice, and I still get frustrated, because really I look at a hospital admission, except for an elective surgery, as a failure of our system in talking to our patients. But that's how we make our money. The sicker the patient is, the more we make. The more time I spent in the ICU, the more I did to you. The more tubes I'd put in you, the more times I'd poke you, the more I personally got to bring home to my family. And to be honest with you, that's sick and wrong. That's a very perverted way of paying for health care. But in reality, it created a system where the hospital came first, the physician second, and the patient last. And if you really look at how the dollars are spent in America today, it's exactly the same way as it was 8 years ago, 10 years ago, 20 years ago, and 30 years ago. The person who gets paid the most first is the building and all the care that needs to be provided in there, and it's pretty expensive care. Then the person providing the care, and the last focus in that whole payment system is the person actually responsible for the payment of it, the patient. And to this day, those volume-based payments still drive the majority of all of our healthcare payments. At Prevea, I'm actually proud to say that about 20, now approaching 25% of our payments are actually value-based, not volume-based, which still means that 75% of how we make our money is based on what I can do to you. And believe it or not, in a majority of cases, some of this is going away. If we mess up, we get paid more. So that is healthcare today. Depressed yet? And that's how we get paid. And that's kind of how we got here. And that's how we got to a national debate. And we are actually blessed to live in the town that we live in. And I couldn't be prouder to represent Green Bay, Wisconsin in healthcare on a national level. For those of you who don't remember, when President Obama got elected, one of his first platforms was healthcare reform. And obviously his signature legislation is PPACA, or the ACA, or some people like to call it Obamacare. Do you all know where it was launched? The first meeting on it? Green Bay, Wisconsin, Southwest High School. Yes, Mayor, you were there with me. I was a guest of the president that day. And if you Google that speech, why did he launch healthcare reform in our town? It's because we have some of the lowest cost and highest quality reported in the country. So we were doing something right. Unfortunately, Air Force One never came back and asked how. And then we got, we got into the politics of healthcare reform. So really, what's the alternative? What is a value-based payment system? A value-based payment system is really where the provider, the physician, the advanced practitioner, the medical group, whoever it is providing care, is actually rewarded for the health of the patient, for keeping that patient healthier. And really, we've gotten an evolution in payment systems around that today. The first, probably released, I know, Tim, you're a healthcare expert in insurance, probably the first pay-for-performance things that I was exposed to about 14 years ago. When we started to see some contracts from insurers that would actually give us a little extra money for doing the right thing. So many of you fly on a regular basis, and on your way out, when the pilot lands safely, do you tip them? That's really what a P4P system is, a payment for performance system in healthcare, is a tip for doing what you should have done right the first time. So thankfully it hasn't progressed to be the primary paying source, because it's one that I don't believe is appropriate. Next is what we'd call in an insurance world a gain sharing contract. In other words, the patient got healthier, the insurance company profited from that because they had to spend less money, and they shared part of that profitability back with the provider, a gain share. We've seen a lot of evolution in gain sharing in Medicare Advantage, and it's worked on keeping people healthier to a point, because there's still a profitability based to the insurance company and back to the provider, and not all of the incentives are completely aligned. And a third area that gets talked about a lot, and for those of you who are maybe a little bit older than me, would remember this concept, which would be a risk-based contract, where the provider is provided a certain dollar amount, a capitation, to take care of an individual or a family. If you go back to the 80s, that'd be called an HMO. And I think we all know how that wound up. But there are some good things about what was going on in the HMO world where capitation made sense. There's also areas where capitation was a failure, and I'll talk a little bit about that. But now we've gotten risk-based contracts that have gone beyond the concept of just capitation and have actually brought quality incentives into it. So when you're capitated, there's also a drive to spend the money in the right places on the patient. So really, in a value-based system today, the hospital gets paid last, the physician gets paid second, but really the person in charge becomes the patient. It's the focus on the patient. But guess what? We have a few barriers to moving to value. I thought I'd have all the answers after Tuesday night, guess not. I didn't hear anything that would help me on this talk, but I'll talk about that. Probably our biggest barrier in America to being able to practice value medicine is our data infrastructure. To be able to do the right thing for the patient, you have to know what's going on with the patient. And because patients can go from one system to another, and that's a good thing, and they can get care in a variety of areas, there's data that sits with their insurance company, and there's data that sits within our electronic medical record. I'm proud to say we became a group that went to an electronic medical record back in 2001. We chose Epic, which means we spent tens of millions of dollars. And I don't know what we've gotten for it yet, but I'll talk a little bit about that. And now actually every system in our area is on Epic. But believe it or not, I can't take data from the insurance company and effectively, easily merge it with that EMR data for proper decision making. We can merge it, but actually using it for proper decision making, that infrastructure in America is still in its infancy in 2017. And it's actually the key reason why HMOs failed. Because back then, there wasn't a data repository at all. It was called a paper chart. You guys remember that, walking in a doctor's office and you had all those charts back there? And a fax machine. Anybody remember what that was? It's kind of interesting. There's only one person in our entire organization that knows our fax number, and that'd be your dad, Megan, just so you know that. He can still remember our fax number. Our chief operating officer, his daughter's an MBA student here, and he's the only one who actually knows our fax number. I didn't know we had one still. But really, believe it or not, you would think where all the money sits in healthcare, the hospitals and definitely the payers would have developed this infrastructure as well. Well, guess what? They're in their infancy as well. They know the reasons they have to do it, that they should do it, but it's hard to try to figure out the delays because really the economics of it is huge. And the federal government, well, you'd expect them to spend some money on this too, but really they're still experimenting in the pilot stage. The ACA, the Accountable Care Act, allowed for some pilots to be done around the value game, the value-based payment system, but it hasn't really evolved outside of pilots. We're actually going to start to see some of our first examples of what we can do in the next 2 years, we think, around value. And the provider groups. Even the largest provider groups in America, the Cleveland Clinic and Mayo, have not fully developed this infrastructure because of cost. The Mayo Clinic is now implementing Epic as well, at a cost of $1 billion is what Mayo is spending to get to where we got to in 2001. It's nice that Mayo finally caught up to Green Bay, eh? Everybody thinks going there is the best. But really, if you look at the cost that we've spent, Prevea's cost alone, the money came out of the doctor's pockets, and then our hospital partners matched that in our partnership in Epic. I'm thinking over 14 years is definitely in excess of $250 million is what we've spent locally on that. It's not a cheap proposition, and yet we can't use the data effectively. But if we weren't using the data, we've spent $250 million on a really expensive version of Microsoft Word. So I'll talk a little bit about Prevea's journey to value, and that's because that's what I know. And I'd like to put a little disclaimer out here. We have two competitors in town who are fantastic, and they are also on their own journey to value. I can only talk about our own. We have a different corporate structure. They have a different corporate structure. Priorities may be a little different, but at the end of the day, you're lucky to live in a town where all three health systems are really focused on moving towards value. And all three could give this speech. So I want to make sure I said that because I can only talk about what I know, what we've been able to do. But I have a lot of respect for them. So really, our journey to value started about 8 or 9 years ago when one of our internists, who's now our chief quality officer, one of my classmates, Dr. Paul Pritchard, said, hey, this way of taking care of patients is wrong, and I need to change it. And I'd like to do a pilot. I'd like to experiment, but I need some money to do it. And at that time, I was a chief medical officer, and I said, I think we should really do this, and we'll find the money to do it. Because any transformation in healthcare, there's not extra money just sitting around to spend. So we had to take it away from something and to spend it on something. And really, we wanted to redesign how we were taking care of our sickest patients, those with chronic disease, high blood pressure, hyperlipidemia, diabetes, and in Paul's case, he's also our leading expert in cystic fibrosis in town, which is a very complicated disease, and that's where his mindset was coming from. And what he wanted to do is replace this episodic way of taking care of an illness and actually always be taking care of the patient, but not just by himself, and that's where the money came into, with the team. Going away from the physician being in the middle, putting the patient in the middle, and surrounding them with experts. And if you think about the traditional doctor's visit, you come in, you check in, you sit in the waiting room, hopefully not too long, we bring you back, we weigh you, we measure you, the physician will talk to you, will likely lecture you about something you don't want to be lectured about, and we then have you check out, and essentially we shove you off the cliff. And we said, come back to see us in 3 to 6 months. We didn't follow up if you listened to anything we said. We don't know if you're taking your medications or not, and we're hoping you're going to make that appointment in 3 to 6 months. We literally abandoned our patient at the end of every single visit. And in Paul's efforts, it was to redesign our patient visit to make it a continuous loop, that the visit never ended. So at Prevea right now, we have care managers that augment what a physician is doing. Now you can see behind me the list of how many we have. But essentially what they do is they work as part of a team to make sure at Prevea your visit never ends. So when you leave, depending on the severity of your illness, so say you're a type 2 diabetic and your blood sugars have been running higher than we like to see. Depending on how high they are, the average, we call that a hemoglobin A1C, depending on that number will depend on how often we touch you or contact you. And in some cases, for the first 2 to 3 weeks after your visit, it may be daily, where we're talking to you about your insulin dosing, your medication dosing, your blood sugars, and we back it off a little bit, but we're always touching base with you. Now, we're proud to say that really within the Brown County area, every single patient with a chronic disease has a care manager looking over them. That, right there, an expense for us on an annual basis is about $2.5 million just to do that. But it works, and we proved it before we actually spent the money. And here's some proof. The yellow bars are those that are medical home patients. The blue bars are those who are not medical home patients. And this is looking at the percentage of patients who receive the recommended care. In other words, they got that number I talked about, that hemoglobin A1C check, they got their cholesterol check. We tested their urine for kidney disease adequately. You can see that the yellow bar is far superior than the non-care managed patient. And you can see that the results, so this is a results page, of those that are care managed are also significantly better. Yellow is better than blue in this case. So we proved that we did the right thing for the patient and that we actually made them healthier. That's great. That's what our goal was. This slide is one that Dr. Pritchard is the most proud of, and the one that has gotten me the most angry, and one of the few times in my office I ever lost my temper. And you'll understand why in a minute. What you can see on the right-hand side, the right-hand bars are really big, is how much a non-care managed patient costs the healthcare system. That is their per member per month spend. About $990 a month was being spent on chronic disease patients. And this is data that we did not track, an insurance company tracked it for us. $990 if you were not care managed. But if you were care managed, only $238 a month was being spent on that patient. Great results, right? One that our entire team should be proud of. The patients got healthier, and we did it for about a third of the cost, if not less than a third of the cost. Anybody know why I got so angry at this slide? We just made the insurance company $700 a month, per member per month. We didn't share in any of that. So we're about to spend 7 figures on this pilot, yet all of the profitability was sitting with the payer at the time. And this was very frustrating because as somebody who took an oath to do the right thing for the patient, I've got to write that $2.5 million check because we've already proven it works. It's like knowing you have a drug that's going to cure somebody and you're not going to use it because of the expense. We couldn't do that. That would violate our oath. So we went out and spent the money. But we didn't get paid a penny for it. And if anything, our payers did pretty well. And we kept asking them for some money, and we got a little bit here and there. We got some table scraps in the deal. But at the end of the day, it did motivate us to really get into the value game, to take the medical home project and look for every single aspect where we could drive value. And then we got ready to do something really prominent because, you know, outside of a few statewide insurance companies, do you know where that $750 difference went per member per month? It left our community, and that angered us even more. It went to Wall Street. If you think about the national payers, these are dollars that were earned in our community, and the profitability here, that delta, left our community. So we had 2 challenges. How do we get a piece of that, and then how do we reinvest it back in the community? Because the only other way we could reinvest back in this community is by raising our prices. And it's not the right thing to do either. So the only thing we could think of doing is, let's become the insurance company. So about 4 years ago, it's actually about 6 years ago after we saw the pilot results, I met with a good friend of mine, Craig Samet, who was the CEO at the time of Dean Health and Dean Health Plan down in Madison, said, we'd like a health plan, but we don't want to spend all the money to get into the game. We want to use your insurance license, and we created a partnership, and that launched Prevea 360. So that was our hospital partners, because they needed to benefit as well, because we were going to take money out of their system, so they needed a way to benefit from that. The physicians could benefit from it, and we needed a partner, but more importantly, we wanted the money to return back to our community. So 100% of the profitability as part of the deal comes back and is reinvested to where the premium dollar was earned. So if the premium dollar is earned in Brown County, it's reinvested here. If it's earned in Sheboygan County, it's reinvested there. And now, for some of you may know, we're now in Eau Claire and Chippewa Falls, and we reinvest our dollars there as well. Concurrently, at the same time, we needed to find a way to partner better with those who are paying the insurance premium. And that's the employer, because the majority of health insurance is still received through the employer. So we developed a track of health and wellness products and actually on-site health care where we would directly partner with the employer around those value things I talked about, around making their population healthier, making sure they would spend less. We branded this Lead Well. Currently, we're up to 50 different employers within the state of Wisconsin that have a Prevea clinic either embedded inside their company or right next door to it in a near-site location. And the size employers range from Kohler to Sargento Cheese to paper converting here locally, the Green Bay School District. We've had a variety of customers that actually we are embedded there, bringing Epic on board into their workplace, bringing the care managers there, and bringing the value equation to them. And that led us to this year, something that we're very excited about, where we now actually have all the claims data from our own health plan. We have our EMR data. And instead of trying to find a software package to marry the two, we found people. And we have a quality department and people who are just dedicated to looking at how the money is being spent and where the EMR data is and what we can then do, the actionable aspects. We call it our AAAs. We have access to data. We can analyze the data by hiring data analysts who actually are medically trained, and then we can actionalize it, whether it be an on-site clinic through Leadwell or health and wellness programming through Leadwell, their primary care physician, or an on-site clinic. We have the ability for that department to say, X patient at, say, X school district has gone to the ER 5 times this month. These are the results. That's very expensive care. It's inappropriate care. It's not where it should be. We need to be talking to that patient, and in some cases, we need to go visit them at home. And we have the ability to do that now. So that's really been our journey from volume to value. Still a lot of barriers out there, and this is how we've tried to overcome some of them. It's probably the biggest thing in your, what you'd like to know is what's going on in DC, and what about the ACA, and how does the ACA and its evolution, I'm not going to talk about replace and repeal and all those things, but how does the evolution of that legislation, that regulation, affect that journey from volume to value? Well, the first step actually, believe it or not, the federal government gave us. And this is a step, you very rarely see this in DC, unless it's naming a building or recognizing or awarding something. This step, this piece of legislation actually had bicameral and bipartisan support. In other words, Republicans, Democrats, House and Senate actually agreed on something. And that doesn't happen very often, just so you know. And it actually was to the doc fix. And some of you have heard that in the press. The sustainable growth rate was a formula used in Medicare that needed to keep getting punted down the line. It was a formula on how physicians and hospitals, mainly physicians, are paid for care through Medicare. It was broken. Everybody in Congress knew it needed to be fixed. Some say they didn't want to fix it because they kept enjoying the lobbying dollars, but it got to a point where they needed to fix it. So they took the opportunity to drive healthcare, believe it or not, from volume to value. And that legislation, the Medicare Access and CHIP Reauthorization Act, is better known as MACRA. And if you talk to anybody in healthcare, they'll groan when they hear about MACRA because it's occupying about 50% of our time right now preparing for it. But at the end of the day, it was our government's first true recognition that we need to move away from the volume game, and that we need to motivate providers. Instead of paying them for sickness, we need to pay them for doing the right thing. And believe it or not, it took us 30 to 40 years to get to this point. And we have it now, for now. I'll point out the for now in a little bit. So it establishes a new way to pay physicians within the Medicare payment system, which is still, depending on your system, can be anywhere from 40 to 70% of your dollars could come from the government. And it incentivizes, there's 2 tracks. One incentivizes quality and service and penalties if you do the wrong thing. That's called the MIPS track. And the MIPS track is about 80% of healthcare providers in America, because not all healthcare providers are organized and have an EMR and are able to take risk. And the second track, the advanced payment model, which is really a risk-based model through the federal government, with still significant quality boundaries around it. So it's not just a capitation. It is, you have a capitation, but you also have to accomplish all of these good things for the patient. So it's an evolution of what failed in the HMOs. Now we're starting to see, believe it or not, through Medicare. It's supposed to go into effect in a year. Now they're saying 2 years. And now the Secretary of Health and Human Services has not made up his mind on what he wants to do with MACRA, because it all sits within his power. And that would be Secretary Price. Some people call him Dr. Price. He's an orthopedic surgeon. Let's not be too kind and give him that title. I'd say that to him, his face too, by the way, and my orthopedic partners. Being an internist, we always tease our orthopedic surgeons on a daily basis. But Secretary Price's mindset is of a single specialty practitioner. That's what he grew up in. He grew up in, I think Tom's practice had maybe 10 docs total when he left it. I'm looking at him because he knows him too from his AMA days, and I know him from his congressional days. But he's not a organized medicine fan. He's not an EMR fan. And he made his money by doing things to patients. So that's the mindset. He is evolving his thought, though, because he has a bigger role. But right now, that is the Secretary's mindset. So we're a little worried. As a representative of my healthcare organization, of a representative nationally of AMGA, I really want to see MACRA go forward. But I'm worried, to be honest with you. So the future of the ACA. The current plan in Congress, and this comes really from the Speaker's notes. Speaker Ryan has 3 ways that he's approaching healthcare reform right now, and it really does sit with the House first, then the Senate, And it really does sit with the speaker, especially because of his background on Ways and Means and his ability to influence Ways and Means, but he sets the agenda. So I was in DC a couple weeks ago, and 2 days before I got there, the speaker had a retreat with his caucus and outlined their strategy on healthcare reform. This is where the blank slide comes in handy. Really, they've looked at it in 3 buckets. The first bucket is actually using the ACA's legislation in its words itself. About 4,000 times in that bill, which is it's a pretty big bill, just so you know. It actually sits this high when printed out. It says the secretary shall. So what that means is the legislative body gave a ton of authority to the regulatory body under the branch of the executive branch to roll out, modify, and pretty much do what it wants with healthcare legislation. Because when they wrote the bill, I don't think it was ever envisioned that it wouldn't be their person doing it. So now Secretary Price is probably the most powerful person in healthcare reform today. The second bucket is the budget reconciliation process, and that's really where a lot of this comes out of. And the third bucket is new legislation. That's a tough road for the speaker right now, because although he's got definite movement in the House, he doesn't have definite movement in the Senate. Because of the midterm elections and because of entitlement reform and the Senate not having that supermajority, it'll be much harder for the speaker to actually get new legislation. So really where the focus is with Secretary Price and the budget reconciliation process. So what the president outlined on Tuesday is really what the speaker had presented to his caucus and actually to all of Congress last week. These are the areas that they plan on touching through the reconciliation process. The first is to eliminate the individual and employer mandate. The second is to replace premium subsidies with a tax credit, repeal Medicaid expansion and look at it from a block grant standpoint, provide state funds to go back to Wisconsin had many years ago, which was a HRSA product or a high-risk pool. It worked. Maybe it'll work again. Sunset the essential benefits. This is something that has really been hard for insurers and providers to live with because it really drove the cost of health insurance up because there were so many benefits that needed to be worked in. So that's a contentious point. It's one that probably needs to be relooked at. I'm not sure, to what extent. And then repealing taxes on medical devices, the Cadillac tax, and a few other things. That's what they've put on now. So what are we missing in that? No mood to value anywhere on there. Patients have no skin in the game. There's no motivation to be healthy in that whole situation, and that's difficult. And once again, no balance once again. All the money is still going to where you don't want it spent. And I love my hospital partners. I'm not saying that they shouldn't receive that, but that shouldn't be the focus of healthcare payments versus the patients. At the end of the day, guess what? It's never going to change. And I have a hard time saying that because I actually represent one of these groups. The largest swamp in DC outside of defense is us. It's healthcare. The American Hospital Association, where the majority of all healthcare dollars roll through, is the largest lobbying group, then followed by AHIP, the American Health Insurance Plans, and then AMGA, the AMA, and MGMA, all having significant voices on the Hill, and none of us agree. So, being the chair-elect, I'm saying drain me. It's going to be very hard for us to see significant movement towards value because so many people here are trying to hold on to what they have. So hopefully that was a nice uplifting 20 minutes for you. At the end of the day, I got asked this question twice actually. With everything going on in DC, are you going to change your path now? I go back to the blue and yellow bars. We did the right thing for the patient. The movement to value and stopping the focus on just the sick patients, that's what's the right thing to do for American healthcare. As somebody who took the Hippocratic Oath, that's the right thing for me to lead. We aren't going to change our path. It may be a little bit more expensive. It may be, I might get a little grayer and lose whatever hair I have left. But at the end of the day, it truly is the right thing to do. So happy to answer any questions either on the volume to value or on DC. So.
Do you think there need to be changes to like the ICD-10 codes and stuff to push for more value rather than person?
So, you know, it's not the codes themselves, it's what the RVU value for that code is. So I think ICD-10 is, basically that's every little code we can have. We even have ones if you got hit by a space alien, believe it or not. If you got stabbed by a turkey, we have that too. Those are all real codes, just so you know. Gotta love the federal government. I actually every year I send those out to my partners as a joke, and they think it's a joke, but I actually pulled the real ICD-10 codes. It's the value associated to them. So why is the value of keeping you healthy, say an activity? We can't even get payment for weight loss, yet I'll get a ton of money to take off your leg because your diabetes was out of control. $6,000 for that procedure, zero money to prevent you from having that procedure. That's what needs to change. Mayor.
What about the students in the medical colleges? Are they being taught differently than, I mean, you're a young doctor, but then these older doctors, are they being taught more what you're trying to get to as a...
I think at a point, yes, but at a point, no. We're still the focus, and it has to be of our training, is to take care of the worst. You know, take care of the sickest. That's what made us good. And, you know, they get more sleep than we used to, which I think is a good thing. I'm not against how they're being trained, but I would challenge one of my medical students, and I do this a lot because I still teach for UW and now for MCW. What have you been taught around counseling a patient on weight loss? They'll talk about caloric restrictions, and they'll talk about a food pyramid developed by the FDA, who also is responsible, in the USDA. And what is the USDA's #1 responsibility? To keep the food producers in business. That's who's designing the food pyramid. Guess what? The food pyramid is not how to lose weight. It's not the right thing to do. So we haven't evolved medical education around keeping people healthy. The focus is still to do what to do when they're sick, which is right, but it's still pretty imbalanced today. Dr. Lee.
What are you doing to incentivize your primary care team to take ownership of patients, even though it may decrease their overall revenue?
So, you know, comp plans are always fun to deal with in medical groups, as you know. And what we get in value-based payments, we've now transferred over to our primary care physicians. We have augmented their compensation for not doing things to their patient, but doing the right things with their patient. And I think that was a huge transformation for us. I'd say about 15% of total payments right now that are building that compensation plan are around value. We'd like it to see it to get to 50% within 2 years, and we're evolving to that. 15% at our last AMGA meeting was, you know, a few percentage points lower than the highest, you know, total that anybody's putting towards that. I'd really like to get to 25 and then to 50. Tom.
So a lot of organizations, including ours, but many of the organizations in the room, we've been trying to move to more awareness, prevention, incentivizing our employees to be more mindful of their health. You've been practicing for some time. In general, do you think that the patients you're seeing are taking more responsibility for their health? Are they healthier? Are they better educated? Or is that needle not moving much?
They're spending less, but they're not healthier. So I think you'll hear this a lot. HSAs and high deductible health plans have reduced our spending. Now what they've done is made sure people weren't spending money when they needed to spend it. I still think there is a lot to do in plan design with insurers around making sure that patients are motivated to do the right thing. Is smoking down? Yes. Not because we did anything, it's because we banned it from the bars. I mean, really, that's the only thing that actually made it go down. If you looked at the trend and everything we've ever done in healthcare, one simple piece of legislation actually reduced our smoking rates more than anything else, and that was the public smoking bill. Not that I'm saying that we need to do that with other things, but I don't think the motivations are there. And more importantly, I think what employers are missing is they're trying to do it with the patient, but they're doing it without their healthcare partner sometimes. So they're creating an incentive, whereas the resources can come from the health systems to help you. Some people do it well, some people don't. But they're creating very small incentives and still paying a lot of money on the other end. And I think it comes down to try to truly reducing that premium to bend that cost curve. The health plan designs need to become more revolutionary than evolutionary for that to really bend.
As you continue to make partnerships with companies like Kohler or others, are you able to change that compensation model a little bit for really helping that team of people become more healthy? Because you're really talking about a smaller community where you can see the change.
Yeah, our contracts there can be really unique. And to be honest with you, we can get more unique. I mean, we're proud to partner with all the companies we have. Where we've gotten really unique is by becoming the insurer. So we can definitely change how we pay our own physicians, we can change how we pay other physicians, and we can change the rates we give somebody based on what they're willing to do for their company's health. So to Tom's question, if you are a Prevea 360 client and you have X number of lives, we likely, contractually, will actually put somebody within your company to focus on health, whether it be a care manager or a nurse practitioner, because now we're at risk. We will make that investment for you. So actually, by being the insurer, we've had much more creativity. The LeadWell products is what we use to augment that.
Maybe one more show.
Pat?
Two-part question. One, how can patients evaluate whether they're physicians of the mindset of doing the right thing versus doing something to you? And two, what can patients do to, I guess, better partner with their physician around the healthcare place?
Number one is, how to become a smarter patient. And I think we as a society need to do a better job of educating around that. And it's also taken away the mindset that patients have that they need something done to them. A great example would be, how many people here have ever had a sinus infection? And how many people 3 days into having that headache and snotty nose think they need to go to the doctor to get an antibiotic because it's another sinus infection? Guess what? You probably have a viral infection. You don't need antibiotics, but you come in with the expectation that we're going to do something for you. And it's that piece of education and things like that, as well as looking at, is there a physician in a program around quality? Is it being measured? Those are the two most important things. But it's a two-way street. We also have to we have to work on patients' expectations around doing something to me, whether it be around the pain you have or the cold you have or the elective procedure you may not need. And then also making sure that you're looking at, is the physician involved in something around quality and incentives around that. The second part question, remind me again, Pat.
You kind of answered it already. What can the patient do with their physician?
Yeah, and really partnering with that physician and listening to that physician. And probably the most important question you need to ask your doctor is, do I really need that? And evaluate that answer. And that will actually be the true judge of that. Are there any alternatives? Do I have to do that? A good physician, a great physician will give you alternatives and let you know the pros and cons of it, both from a cost standpoint and an outcome standpoint. Very few times are there not a second option. And sometimes that second option is doing nothing and knowing that you may die, but you may be 99 years old and on a cath lab table and you may be going, do I really need this done? But it still happens in this community.
Please join me in thanking Thank you, Ashok. Terrific presentation, and I'll return the compliment in all sincerity by saying that it's been wonderful to watch Ashok's leadership of Prevea. I think it's not only one of the most creative healthcare organizations around, but just one of the most inventive organizations, period. And he just briefly touched on his role with his national organization, but he's going to be in the room for a lot of important conversations as we go forward. So I'm sure stay tuned, and chances are we'll ask you back for give us a report card. So again, thank you, Ashok. Terrific presentation. If you would like a DVD of today's presentation, please see Amy Sorensen, who's right over here, and she'll get you squared away. Also want to make sure you can join us for our next CEO breakfast. That's going to be on March 23rd. That's Wilson Jones, who's the president and CEO of Oshkosh Corporation. He's going to speak on the topic of making a difference. That's going to be down at our southern location at Butamore Country Club, March 23rd. So hope you can join us. Thank you again for coming out. It was wonderful to see you. Please be careful on your way out and back to work, and we'll see you in a few weeks. Have a great day.